Assalamu alaikum everyone. Today the topic of discussion is chronic myeloid leukemia, which is a type of myeloproliferative neoplasm involving hematopoietic stem cells that result in overexpression of the myeloid cell line, especially granulocytes. Granulocytes are neutrophil, eosinophil, and basophil. It is caused by translocation between chromosome 9 and 22, resulting in the formation of Philadelphia chromosome, which contain the BCR-ABL1 fusion gene. The BCR-ABL1 fusion gene encodes a hybrid tyrosine kinase. With increased enzyme activity, they lead to unregulated proliferation of hematopoietic stem cell. The cells subsequently differentiate into mature myeloid cell, resulting in CML. It's more common in male, and peak incidence is about 50 to 60 year. Etiology, so in the most of the cases, its cause is unknown. Ionizing radiation and aromatic hydrocarbon, especially benzene, can lead to the development of CML. Pathophysiology, so there is Philadelphia chromosome, which is reciprocal translocation between chromosome 9 and chromosome 22, formation of Philadelphia chromosome. Fusion of the ABL1 gene on chromosome 9 with BCR gene on chromosome 22, so formation of BCR-ABL gene, which encodes a non-receptor tyrosine kinase with increased enzyme activity. So what is the result? Inhibits physiological apoptosis and increased mitotic rate. So mitotic rate is increased while apoptosis is suppressed, result in uncontrolled proliferation of functional granulocytes. So Philadelphia chromosome is present in about more than 90% of patients with CML. In ALL, about 20% of adults, while 5% of children have Philadelphia chromosome, while in AML, it's very rare, less than 2% of the patient. Genetic changes and clinical course, so additional chromosomal changes and the mutation of tumor suppressor gene and oncogene P53, RP1, and RAS, which emerge during the course of the disease, are responsible for the progression from the chronic to accelerated phase and ultimately the transition to acute leukemia. Clinical features of chronic phase can present up to 10 years and is often subclinical. When symptomatic features include B symptoms and splenomegaly, due to which there is abdominal discomfort in the left upper quadrant. Lymphadenopathy is not typical in CML. Unlike AML, CML is not characterized by recurrent infection during early stages because the granulocytes are still fully functional. The second phase is accelerated phase. So accelerated phase present with erythrocytopenia, which will present as anemia, neutropenia, so patient will present with infections and fever, extreme pleocytosis, which is rapid proliferation of the malignant cell, result in leukostasis and formation of leukemic thrombi. These thrombi block different vessels, leading to splenic infarction, myocardial infarction, retinal vessel occlusions. They can block the vessels, leading to leukemic priapism. And terminal phase, it leads to myelofibrosis. Extreme splenomegaly, 75% of patients with CML, palpable in lower left quadrant or pelvic cavity. Then we have blast crisis. Blast crisis is the terminal stage of CML. Symptoms resemble those of acute leukemia. Rapid progression of marrow failure, so leads to pancytopenia, bone pain, severe malaise. There are two subtypes, one is myeloid and other is lymphoid blast crisis. So in myeloid, AML present in 2/3 of cases, while ALL present in 1/3 of the cases. So we have three phases of the CML: chronic phase, accelerated phase, and blast phase. Diagnostic approach, so clinicians should maintain high index of suspicion in if patient present with the following: severe leukocytosis, which are mainly granulocytes, splenomegaly, and constitutional symptoms like malaise, fatigue with non-specific signs of marrow suppression, anemia, thrombocytopenia. Initial workup includes CBC, smear, and bone marrow aspiration and biopsy. Diagnostic confirmation is Philadelphia chromosome and RPCR, BCR, ABL1 fusion gene identification. Evaluate patient without Philadelphia chromosome or the BCR ABL1 fusion gene for other myeloproliferative disorders. CML can cause extreme leukocytosis, often greater than 1 lakh, and is frequently associated with basophilia. On CBC and smear, you will have the finding of leukocytosis with mid-stage progenitor cells, like myelocytes, metamyelocytes, and mature cells, for example, neutrophil. The presence of mid-stage progenitor cells allows CML to be differentiated from AML, in which a leukemic hiatus is present. In AML, we have leukemic hiatus, which means that there are blast and mature cells, but no mid-stage progenitor cells are present. While in CML, we have all forms of cells maturations presents. Then we can have thrombocytosis, basophilia, and eosinophilia. Blast cell in the smear can indicate the transition to accelerated phase CML and anemia. These are the finding of the smears. These are promyelocytes. These are the mature neutrophils. These are the bent neutrophils or stem cells, and these are the lymphocytes. So different types of maturation and different stages of the cells are present. This is another image showing promyelocytes, segmented granulocytes, megakaryocytes, and these are the platelets. So all stages of maturation are present here as well. This is the picture showing eosinophils. These are the different types of eosinophils present here. Further lab studies, so we will have low alkaline phosphatase level, and it's a typical finding that can help distinguish CML from other type of leukemia and leukemia reactions. We can also do flow cytometry that can assess the type and maturity of the leukocyte. Bone marrow aspiration and biopsy indicated in all patients with suspected CML. Supportive finding will be hyperplastic myelopoiesis, predominantly granulocytosis, with elevated granulocyte precursor cells, especially myelocytes and promyelocytes. So there will be increased granulopoiesis by erythropoiesis index. Diagnostic confirmation relies on the detection of Philadelphia chromosome and or the BCR-ABL1 gene or its transcript in the marrow or the blood. The tests are usually repeated to assess response to treatment. Cytogenetic testing and molecular testing. Cytogenetic testing, we are used to confirm the presence of BCR-ABL1 fusion gene and or the Philadelphia chromosome. We have conventional karyotyping and FISH analysis. Conventional karyotyping for confirmation of the Philadelphia chromosome, which contains BCR-ABL1 fusion gene, and FISH analysis for confirmation of the BCR-ABL1 fusion genes. So these are the two types of cytogenetic testing, and then we have molecular testing, quantitative RT-PCR, which is reverse transcriptase polymerase chain reaction. Identification of BCR-ABL1 fusion gene is the hallmark of the CML and confirm the diagnosis. Now definitions of CML phases. So we have accelerated phase, blast phase have characteristic lab parameters like the proportion of the blast cell in peripheral blood or marrow. In accelerated phase, we have significantly increased proportion of the blast cells, 10 to 29% according to MD Anderson classification criteria, or 10 to 19% according to WHO criteria. While in blast phase, higher proportion of the blast cells compared with accelerated phase, greater than 30% according to the MD Anderson classification criteria, are greater or equal to 20% according to WHO criteria. Extramedullary blast proliferation often resistant to target therapy due to the presence of multiple genetic mutations. The presence of additional mutation is associated with more advanced stages of CML, accelerated phase or blast phase, and can cause resistance to target therapy. Blast phase is a life-threatening condition that is clinically similar to acute leukemia. It should be recognized early and treated immediately. Treatment approach. So according to the phases, chronic phase, TKIs, tyrosine kinase inhibitors are the first line and second line treatment option, and adjunctive medical treatment or hematopoietic stem cell transplantation may be considered if other treatments fail. Accelerated phase, so begin with TKIs, consider systemic chemo or hematopoietic stem cell transplantation if the patient is eligible. Blast phase treatment is similar to acute leukemia, aggressive systemic chemo in combination with the TKI. Hematopoietic stem cell transplantation is in patient if the patient is eligible. Targeted therapy, which are tyrosine kinase inhibitor, indicated in all patients with CML. Agents, first generation, second generation, and third generation. First generation are imatinib, indicated in low risks chronic phase CML patient with comorbidities or older patients. Second generation dasatinib or nilotinib, usually indicated in patient with accelerated phase, while third generation, for example, ponatinib, especially effective in patient with additional mutations. Mechanism of action, selective inhibition of tyrosine kinase by blocking its ATP binding site, inhibits tyrosine phosphorylations of downstream signaling proteins, so no transfer of phosphate transfer from ATP to tyrosine residues. Disruption of the BCR-ABL pathway, inhibition of proliferation and induction of apoptosis in BCR-ABL1 positive cells. Special considerations, so second and third generation are more effective in patients with certain additional mutation than first generation, but are also associated with more adverse effect. TKIs can interact with many common medication and herbal supplements like antacid, antidepressants, green tea, etc. They are teratogenic, therefore they should not be used during pregnancy. Interferon can be used instead of TKs during pregnancy. TK are the primary drug used to treat CML. Further treatment options so hydroxyurea or interferon alpha may be used to reduce leukocyte count and control symptoms associated with extreme leukocytosis or thrombocytosis. Systemic chemo indications are blast phase and certain cases of accelerated phase CML. Allogenic stem cell transplantation should be considered in patients with TKI resistant CML and certain patients in advanced phases like accelerated phase or blast phase CML. Differential diagnosis. Here is a table which gives summaries of the differential diagnosis of CML. We have polycythemia vera, in which we have all cell lines are elevated, erythrocytosis, thrombocytosis, leukocytosis, lab score is also elevated, and JAK2 mutation is present in 95% of the cases. In primary myelofibrosis, there is pancytopenia with dacrocytes which are in the shape of teardrop. Lab is elevated and JAK2 mutation 60% of the cases. Essential thrombocythemia, isolated thrombocytosis. Lab score elevated and JAK2 mutation in 50% of cases. Then we have CML, in which we have extreme leukocytosis, basophilia, neutrophils may have the pseudo Pilger-Hute anomaly, and here the lab score is decreased. So in these all of the diseases, leukocyte alkaline phosphatase is elevated, while in CML it's decreased. What will the genetic cause? Philadelphia chromosome. Then we have leukomyid reaction, so in which we also have leukocytosis but fewer granulocytes as compared to CML. Neutrophils have toxic granulation, toxic vacuolation, and Dohle bodies. So a lab will be elevated as in contrast to CML where it's decreased. No mutation typically secondary to infection or drugs like steroids associated with certain solid tumors, for example lungs cancer, kidney cancers. Prognosis of survival rate without treatment for chronic phase 3.5 to 5 year, blast phase 3 to 6 months. In most patients, life expectancy can be markedly improved through targeted therapy with imatinib. In some cases, it even results in molecular remissions. So these are the some points. The patient presenting with CML will have age about 40 to 50 years. There will be massive splenomegaly. CML is a mnemonic, crazy, massive, large spleen. The WBC count will be elevated more than 1 lakh or greater than 100 multiplied by 10 raised to power 9 per liter. Granulocytes will be present at all stages of maturation, but without blast cell there will be no blast cells. Predominantly neutrophil, myelocyte, eosinophil, basophils. Cytogenetics will show Philadelphia chromosome translocation. So that's all about chronic myeloid leukemia.